Good morning, everyone. So I will be talking on small cell lung cancer extensive disease, second line treatment and beyond. So it's a neuroendocrine carcinoma with that 13 to 15% of all cases. It has been discussed multiple times in the previous discussions. So workup, we all know about this. PET-CT with the brain imaging is essential with a biopsy with immunohistochemistry. So incidence-wise, limited stage and extensive stage, it's more common of an extensive stage. Overall, the incidence is less of small cell lung carcinoma. So this is the management approach of first limited stage small cell lung carcinoma. So for systemic therapy for relapsed small cell lung cancer, so definitions and response rates. So if the disease-free interval was less than 3 months from the last day of initial treatment, we call it as a resistant relapse. And if there was no initial response, we call it as a refractory disease. So if the disease-free was more than 3 months, we call it as a sensitive relapse. So response rates in sensitive relapse in the second line treatment options are around in the range of 25%, whereas in the resistant relapse, it's around 10%. So the main goals of treatment, the major goal is to have a symptom control with a good quality of life. The other goals are to improve the survival, the response rates, and increase the time to tumor progression. So the factors which we consider prior to treatment initiation is the ECOG performance status, which is the most important factor, the age of the patient, the previous treatment toxicities, the treatment-free interval, the presence of brain metastasis, and the prior chemotherapies which were used. So systemic therapy for relapsed small cell lung cancer is given to patients who has an adequate PS with tolerable and to tolerate the toxicities of the treatment. If they have a worse PS at any point of time, we generally plan it for a supportive care alone or a palliative treatment. So this is the treatment regimen for carboplatin plus etoposide in first line setting in extensive stage with carboplatin of AUC5 and etoposide 100 mg per meter square day 1 to day 3. Cisplatin is also incorporated in place of carboplatin with 80 mg per meter square and etoposide with 100 mg per meter square day 1 to day 3. So the toxicities which we all know, it's myelosuppression, neurotoxicity, nephrotoxicity, and others. So this is the NCCN guideline in NCCN chart for primary treatment for extensive stage and systemic therapy for subsequent relapse. If we have relapse less than 6 months, the preferred regimens are topotecan, which may be used per oral or IV, and another drug, lurbinectedin, which has come into the picture, and the others are clinical trial. And relapse, if it is a more than 6 months relapse, then we go ahead with the original regime, which was either a carboplatin or a cisplatin plus etoposide based regimens. Other recommended topotecan, the paclitaxel, the docetaxel, irinotecan, temozolomide, which we can use. So this is in this is a diagram showing the stage treatment of extensive stage small cell lung cancer in short. So the chemotherapy regimens for extensive stage atezolizumab plus carboplatin and etoposide, which was discussed in the last presentation also. The rationale has also been discussed. So the practical considerations for dosing atezolizumab, which we use at a dose of 1200 milligram every 3 weekly based as studied in the IMpower 133 trial, along with carboplatin and etoposide, with maintenance of atezolizumab alone till progression or unacceptable toxicity. Next is the durvalumab, which was approved in 2020 with a dose of 1500 milligram IV over 60 minutes every 21 days, along with carboplatin or cisplatin plus etoposide with maintenance durvalumab till unacceptable toxicities. The side effects of the immunotherapeutic agents, which we told, what we talked, that it can be diarrhea in the form of diarrhea, immune-mediated side effects, which are additive and not synergistic. The neurological paraneoplastic syndromes are considered immune-mediated. Along with that, the pneumonitis, the gastrointestinal diarrhea, fever, pain, which we can have. So management of immune-mediated adverse events, mild to moderate, is mainly a symptomatic management. And if the patient, if needed, we need to delay the immunotherapy until it has resolved to less than grade 1. And if it doesn't improve, we can use steroids. And if endocrine related events happen, so we can go ahead with hormonal therapy for that. So practical considerations for topotecan, which are available in the form of capsules and IV. So it can be used at the dose of 2.3 milligram per meter square every once daily for 5 days, starting on day 1 of a 21-day cycle, 3-weekly cycle, and IV it's 1.5 milligram per meter square over 30 minutes for 5 days in a 21-day cycle. So next comes lurbinectedin, which is a congener of trabectedin, which we use for sarcomas. It received FDA approval for treatment of adults in metastatic small cell with progression after a platinum-based chemotherapy regimen. So it was preferred in patients who relapses less than 6 months from the prior treatment, or if it's a resistant relapse. It is used at a dose of 3.2 milligram per meter square IV over 60 minutes on day 1 in a 3-weekly cycle till progression. So it's second line and synthetic analog of a marine alkaloid trabectedin, inhibitor of an alkaline active transcription factor. There are phase 2 studies for this with an overall response rate of 35.2%, whereas in the platinum sensitive subset it's 45%, and in the resistant it's at around 22.2%. So this is the subset analysis based on this chemotherapy-free interval, if it is less than 90 days or more than 90 days. So in the resistant relapse, which we told that the response is around 45%, and in the resistant relapse it's less. So the toxicities of lurbinectedin are mainly hematologic toxicities in the form of anemia, cytopenias, leukopenia, neutropenia, and thrombocytopenia. These are the main side effects which occurs with lurbinectedin. Along with that, fatigue and nausea with decreased appetite and vomiting are some other side effects of this drug. So newer drugs in the pipeline is rovalpituzumab tesirin, which is an antibody drug conjugate targeting the DLL3 protein, which is in the phase 2 study with an overall response rate of 13.2% and overall survival of 5.6 months in the DLL high group. And some other drugs which uses BiTE cells or bispecific T cell engagers and chimeric antigen receptors, which are in the development phase in phase 1 trials are recruiting. So in short, the treatment options less than 6 months and more than 6 months, which we saw earlier also. And clinical trial is strongly suggested for any patient with relapsed small cell lung cancer in an extensive stage. This is the ESMO guideline also, which suggests that if it's a refractory relapse and more than PS2, we call it, we plan it for a supportive care alone, or at best, lurbinectedin can be used. And if it's less than to a PS2, we can go ahead with the topotecan-based treatment also. And if it's a sensitive relapse, we can go and re-challenge the same regimen which was used earlier. So the take-home messages are options beyond second line is less. A single-agent chemotherapy is the standard second-line treatment after platinum-based chemotherapy and immunotherapy. So lurbinectedin or a camptothecin represents our preferred initial approach. If it is associated with milder toxicity profile, progression-free survival and the performance status are the major determinants of treatment, and no data on reintroduction of chemotherapy in patients with late relapses on maintenance immunotherapy is there, and patients with late relapse who did not get immunotherapy in the first line, reinduction with chemotherapy and immunotherapy has shown some promising results. So with this, I end my talk.
Thank you, Dr. Tanmoy.